Hello, I'm Nancy Reau from Rush University Medical Center, and I'm at the 5th Annual Liver Connect in San Antonio. Today, I'm going to be discussing some of the challenges with primary biliary cholangitis. So, number one of our biggest challenges is just recognition of disease. So in our own center, we looked at patients labeled with PBC or found to have PBC, and sometimes there was a 7 to 11 year delay between abnormal liver enzymes and symptoms that clearly suggested the diagnosis until they actually received the label, which connected them to treatment. So I think that we have to improve awareness, fatigue, itching, cholestatic blood work that doesn't have to be off the charts, but that increase in alkaline phosphatase. These are our early symptoms of PBC, and really getting tested then with the antimitochondrial antibody. And if that's negative and suspicion is high, some of those PBC-specific antinuclear antibodies really helps move to earlier diagnosis, which means earlier therapeutics and better prognosis. I think one of our second big issues is that we tend to be a little bit hesitant to escalate treatment. So traditionally, our guidelines really didn't have a lot of options. So we had ursodeoxycholic acid, which was weight-based. And if that didn't work, it's not like we had a huge toolkit of alternative choices. There were some things that we tried, but we didn't have second-line therapy. And then when Obeticholic acid was approved, things are new. We don't like change. I think there was a lot of hesitancy to say, this patient with PBC has suboptimal response. Let's try another agent. And then even when we did try another agent, OCA does have some side effects. They are not insurmountable, but I think that led to a little clinician and patient hesitancy. And so we would, again, kind of drag our feet. We will occasionally use things off-label, like fenofibrate, especially in our patients that were itchy. But again, the package insert says it's a bad idea. And if you have a patient who's got more advanced disease, then fenofibrate wasn't really a good choice for our patient population. Now we have 2 new PPAR therapies. They're FDA-approved for second-line treatment, have demonstrated safety in well-compensated cirrhosis, and so we have to stop dragging our feet. We have to look at these biochemical remission signals, so that normalization of your alkaline phosphatase, that total bilirubin less than the upper limit of normal. And if you have not achieved that in a reasonable period of time on a first-line treatment, then you really need to talk about second-line therapy at an earlier time point, not when the disease has progressed and we've lost some of the opportunity to lead to better long-term outcomes, better transplant-free survival, better quality of life. So diagnosis, big delay. Escalating therapeutics, again, a big delay. And I think if these are our 2 things that we can concentrate on, our patients with PBC will really have a much better outcome.